Hello, and thank you for joining us for today's session on how to integrate home phototherapy into the modern dermatology toolbox. My name is Dr. James Song. I am a board certified dermatologist, the director of clinical research, and I also run our Inflammatory Skin Disease Center at Frontier Dermatology. And one of the byproducts of living and practicing in the Pacific Northwest is that we all tend to be a little bit more kind of natural and crunchy and granola. So as you can imagine then, despite having a lot of great therapies for inflammatory skin diseases, our patients, they still really want more of these kind of natural holistic options. And that is why we are one of the busiest phototherapy centers in our state, but the reality is that it's very hard sometimes to have these large devices. They take up a large footprint. They can be costly to maintain, and even for our patients, it can be sometimes a challenge to take time off of work and pay the copay every time that they come in. So while this is a therapy that has been established for centuries with good efficacy, safety, and tolerability, a lot of patients have not had access to this treatment modality because of that inconvenience piece. What I want to convince you today, though, is that we have the ability to have that same type of treatment that we've been doing for years with UVB therapy, but we can deliver it safely and effectively in the comfort of a patient's home. And that is really what we're going to focus on today. Now, this program is being sponsored by Phothera, and as I said before, I'm a board certified dermatologist, and I do work at Frontier Dermatology, and my area of interest is in inflammatory skin disorders, which we'll be talking about today. Now, who is Phothera? And many of you may be familiar with Davalin and National Biologic. These are the two largest manufacturers and distributors of phototherapy for a very, very long time. But now they've come together to form one company, which is Phothera, and they are now giving us over 80 years of combined phototherapy experience. So they have a lot of data and experience in this space. So what we're going to talk about today is number one, introduce phototherapy as an important tool in our toolbox. And we're going to talk just very kind of briefly about the history, how does it work, what's the efficacy and safety like, and also include some real case examples. And then we're going to address some of the barriers that we've had historically with home phototherapy and how we're going to get around that. And then we're going to reintroduce this new era of home phototherapy, right? And not only is it the same technology, but it's actually improved in that we can now have more control of how the dose is administered to really prevent some of the issues that we've had in the past with maybe administering the wrong dose and then leading to a poor patient outcome. And then just discuss some best practices of how to get the most out of phototherapy, and then lastly, we'll have actually some representatives from Phothera talk about best practices as far as how to get this approved. What are some of the things logistically that you have to know as a prescriber or a back office staff to make sure that your patients get access to this treatment? I'm going to start off with a real patient case. This is a patient of Dr. Christina Callistuffin, 60-year-old male with plaque psoriasis for 35 years and extensive body surface area. Essentially, a quarter of his body is covered with psoriasis. He's tried apremilast, as an oral PDE4 inhibitor. Had side effects, not a surprise with this medication. Tried topicals, ineffective, and that's not a surprise as well because he has 25% BSA. He actually had phototherapy in the office, which proved to be effective, but it just wasn't available anymore for this patient. And he had an upcoming hip replacement surgery, and his surgeon wanted his skin to be clear so they could operate on his skin. Because, as you know, if you traumatize the skin by making an incision, that could lead to what we call Kevnerization, so worsening of the psoriasis. And oftentimes, our surgeons don't want patients to be on systemic agents due to the potential of maybe increasing the risk of infection and a surgical site complication. And so, phototherapy really would have been ideal for this patient. But unfortunately, this patient no longer had access to that therapy. This is actually my patient case, 62-year-old female with Crohn's disease and plaque psoriasis, had it over 5 years, previously treated with adalimumab and infliximab. These are both TNF alpha inhibitors. It did a good job of controlling the psoriasis, but it wasn't addressing the GI symptoms, or at least not effectively enough. And so her gastroenterologist decided to change her to ustekinumab, which is an IL-12/23 inhibitor. Actually, the GI symptoms finally improved, but interestingly enough, the psoriasis started to come back. And this is a photo of this patient on ustekinumab, 90 milligrams every 8 weeks, which is actually a higher dose than what we use for psoriasis. But because this patient's Crohn's disease was so difficult to control, her GI doctor did not want to change any other type of therapy and told us we got to figure it out to get the skin better. Now, of course, we've tried topicals, we've tried methotrexate, didn't work. And so we started this patient on home phototherapy. So this is a patient that was actually in one of the studies that we'll be discussing later on today. And this patient had an excellent outcome. So this is actually her 12-week photo, stayed on ustekinumab, but we added narrowband UVB at home. And this patient till this day remains completely clear. GI symptoms are still under well control with ustekinumab, and patient is just overall very happy. Now, we're going to focus a lot on psoriasis because that is one of the first indications for phototherapy. But I just want to remind you that phototherapy can be used for a lot of other skin conditions as well, including vitiligo. At least in my experience, I think narrowband UVB is the most important treatment for vitiligo, and I actually offer it to all my patients, even if they're using topicals and have localized disease. And that is because there is some evidence that even in areas that are not actively depigmented, they may depigment in the future. So by offering phototherapy that could treat a larger area, we are stabilizing the disease to prevent new areas from forming. Prurigo nodularis, we know that could be due to both neural and immune mechanisms. We know that phototherapy can actually address both. And so it's actually a really nice option for these patients, especially because they often have a lot of other comorbidities, polypharmacy. So you don't want to give them a medication that's going to cause a drug-drug interaction. So we could very safely and effectively administer UV therapy for these patients. And then atopic dermatitis. Yeah, this is also a very good option for patients that want to use something more natural and holistic, whilst maybe still just being managed with topicals. The one thing that I will say though is if a patient is actively really red and inflamed, you may want to cool them off a little bit with a topical or a systemic before administering the phototherapy, but still a very good option for these patients as well. Now, let's just do a brief overview of what is actually UVB therapy. Okay, most of you are probably familiar with this, but UV light is just one portion of the entire electromagnetic spectrum. And we're looking specifically at 100 to 400 nanometers. That is the UV spectrum, which is thought to have the most biologically active activity. Now, from uh, 100 nanometers to 280 nanometers, that is what we call UVC, which is not good for humans. Fortunately, all of that is blocked out by the ozone. And then from 280 nanometers to 320, that is the UVB spectrum. That is thought to be the most effective for inflammatory skin disorders. And then from 320 all the way up to 400, so right below visible light, that is UVA, which is more deeper penetrating, and we think has a higher risk of photo aging and carcinogenesis. So we really want to look at UVB. Now, from 280 to 320 nanometers, we call that broadband. So you're still getting the efficacy, but there is a higher risk of burning and causing unwanted side effects. So we narrowed it even more to look at 311 to 313 nanometers. That is the idea behind narrowband UVB. So we're trying to leverage all the wonderful benefits of photobiology, but just trying to minimize the adverse events and risks by just using that narrow spectrum. And what we know is that UVB can modulate the immune response without causing systemic immunosuppression. So a great option, especially for those patients who might have cancer or who are on other immunosuppressant agents, because we don't want to doubly immunosuppress them. And this has been shown to be effective, safe, and FDA approved for treatments like psoriasis, AD, vitiligo, early stage MF, pruritus of unknown origin, and many other conditions. And this can be delivered not just in the office, but now we have the ability to do this at home. And that is really what we're going to be talking about today. How does UVB therapy work? a lot of different mechanisms that have been described, so quite a pleiotropic level of effects here. But we do know that UVB has both an anti-proliferative effect, so it normalizes keratinization, which makes sense why this works for psoriasis, but also could cause direct apoptosis of these pathogenic T cells that are infiltrating into the skin. Also could downregulate antigen-presenting cells, which we know is one of the earliest stages of activating these immune axis pathways like Th1, Th2, Th17, or Th22. And in the context of vitiligo, we know that UVB is important for these melanocyte precursors to migrate from the bulb to the hair to the skin, as well as activating these melanocytes to make more melanin. And so, a lot of different positive effects with UVB therapy, but notably, there is no systemic immunosuppression, which is really the advantage here of UVB. We have a number of studies for UVB in these five different conditions. I don't think the numbers here are as important. Just note that these numbers are actually very comparable to some of our best systemic therapies, especially in psoriasis, right? A PASI 75, somewhere in the 75% range, is actually very, very good. We're seeing good results with atopic dermatitis, whether you're looking at the EASI or the SCORAD. And MF, we're looking at the MSWAT. That is one of the endpoints used in assessing efficacy in this condition, and then VASI for vitiligo, and then NRS, or the VAS itch score for pruritus. One thing I will say here is that we sometimes encounter patients that can have this kind of psoriasis and eczema overlap, and we're not sure which one it is. Or sometimes it just looks like they have chronic dermatitis, and you're worried in the back of your mind that this could maybe be early MF. And as you all know, MF is very difficult to diagnose, especially in its early stages. Sometimes you have to do 3, 4, 5, 6 biopsies before we could actually make that diagnosis. And we are sometimes a little concerned of using a biologic that can maybe unmask that mycosis fungoides. And so I often really will turn to light therapy, UVB therapy, to treat those patients, because it really doesn't matter whether it's psoriasis, eczema, dermatitis, NOS, or MF. Just knowing that we can treat all of these conditions safely and effectively is one of the reasons why I still use this treatment a lot for those patients where I'm still not clear cut on what the actual diagnosis is. Now, why phototherapy? Well, it still is a preferred treatment amongst a lot of our colleagues, but also patients. Patients have a strong preference for phototherapy if it is an option. The reason, at least in my experience, that patients don't like phototherapy is the inconvenience piece. They have to come into the office 2 to 3 times a week and pay a copay, right? If we remove that, I think a lot of our patients, maybe the majority of our patients, would prefer to start with phototherapy based on the value proposition of efficacy and the safety. Speaking of safety, as we mentioned, no systemic immunosuppression. Until this date, there has been no studies to show that it increases the risk of skin cancer. And mind you, this has been studied extensively. And even in vitiligo, we've seen that the risk of skin cancer actually goes down. And there's very limited monitoring that's needed. You don't need blood work, just an occasional check-in with your providers to make sure that they're responding well. Of course, there's no needles and few adverse events, which are really just limited to inappropriate or improper dosing, as we'll talk about. This is a cost-effective treatment compared to our biologics and small molecule inhibitors, which are wonderful medications. They are also very expensive. And when you look at various cost per responder analyses, what you'll see is that narrowband UVB is one of the most cost-effective ways of treating patients. And also, it's very versatile. I mean, you can use it as monotherapy just by itself, although I typically recommend using some type of emollient like a petrolatum or mineral oil before UV therapy because it really helps with better penetration. But you can also combine it with other therapies. There's nothing telling you you cannot use it with a systemic agent, whether that's a biologic or an oral agent. And there is potential here for remission. And we've seen this with the Geckerman therapy, where you have coal tar, you get exposed to UVB therapy, and these patients could get completely clear and stay clear for a very, very long time. So, in fact, this idea of remission first came from the Geckerman therapy, and now we are seeing it with our biologics. But you also have the ability to start and stop phototherapy, which is one of the real great attributes of this, because with biologics, and small molecule inhibitors, I generally discourage patients from starting and stopping the medication because we do see over time that seems to affect the response, whether that's due to increased metabolism of drug neutralizing antibodies. But for phototherapy, we really don't see that. So patients do have really the ability to take a holiday from treatment if they wanted to. And then once their disease starts to, or if their disease starts to flare, they could go right back on therapy and get to where they were before. Now, what are some of the reasons why patients or providers may not want to do phototherapy? Well, there's a couple misconceptions that we just want to clarify. First off is the skin cancer risk. I already kind of alluded to this before, but there's large meta-analyses that have been done showing that the skin cancer risk is low, consistent with the background rate, and it's actually lower in vitiligo patients. So there's that. Efficacy. I think there are people out there that just don't feel like at-home phototherapy is going to be as effective as in-office therapy. But maybe the bigger concern is the safety. If there is no one that's monitoring the patient and punching in the numbers correctly, maybe those patients will be at a higher risk of burning. So that is one of the concerns that our colleagues have expressed. And the challenge to prescribe. And I will admit, even for me, until I started to work with Phothera, and use this myself, I did believe that it is harder to prescribe home phototherapy devices just because there wasn't a clear path forward. Like, what do you actually do to get this approved? Because it wasn't something that was utilized all that much. And then biologics are preferred. Okay. And this I would disagree with. I mean, yeah, I could convince a patient to go on a biologic if I really want them to. But if we were to offer patients all these different options and said, hey, you could do phototherapy and you don't necessarily have to come into the office to do them, right? I think there's a lot more patients that probably would prefer to start with a phototherapy device at home before they move on to an expensive and invasive biologic. Now, we talked a lot about data up to this point. I shared some of my own anecdotal evidence, but we need larger studies to prove that at-home phototherapy is as good as in-office therapy. So to answer that question, there was this large study. This is the largest of its kind, called the LITE study. It's the LITE Treatment Effectiveness Study that was co-led by doctors Joel Gelfand and Christina Callis-Duffin. And it looked at over 1,000 patients that were stratified based on skin type, as you can see below, and they're randomized 1-to-1. And you either got the in-office treatment, which is per your protocol, or you got the at-home phototherapy device, which we'll talk about later, right? But we wanted to really just check to see, is this as effective? Is this as safe and well tolerated? And we followed these patients through 12 weeks. That was the primary endpoint. And then we followed them additionally for another 40 weeks to get some additional safety endpoints. The real neat thing about this study was that it's a pragmatic study, which means that this was embedded in your normal routine clinical practice, right? If you look at the inclusion and exclusion criteria in the bottom here, there's very little, right? This isn't like a randomized control trial for an investigational drug where you had to have a certain PASI, a BSA, or an IGA, right? And that you were excluded if you used other concomitant treatments. Here, as long as you had psoriasis, you're 12 and up, and it could be even guttate psoriasis. Okay, you were eligible to be in the study. There was no PASI requirement. You could have a PASI 5 or a PASI 50. Okay, and there was no exclusion of what you can or cannot use. So for many of these patients, they were using topicals in addition to phototherapy, which would normally not be allowed in an RCT. And actually, 12% of patients were on a systemic or a biologic at the same time. So we actually have a lot of data of combination usage. And then we had various different skin types and tones that were represented. We actually had over 80 patients with skin type 5 and 6. And that's important because these are the types of patients that generally are harder to treat because they have more melanin. So we sometimes will have to increase the dose more. And then we had a good representation of private practices, hospital groups, as well as academic centers. If you look to the right, that is the baseline characteristics of the patients in the study. Average body surface area was about 12%. High DLQI, so that's a dermatology life quality index. Higher the number, the more of an impact the disease has on one's quality of life. So any score above a 10 means it has a large impact. 40% of patients were on a systemic or a biologic before, so very, very systemic experience. And as I mentioned, 12% of patients were on a concomitant systemic therapy at the same time as phototherapy, like that one patient I showed you earlier on. And this is the upshot of the study. We're looking at two different endpoints, a PGA of clear or almost clear, which is a very stringent endpoint. That means you literally can not have any visible psoriasis or barely perceptible psoriasis. So essentially you're clear or almost clear. And then also a DLQI of mild, meaning your disease now has only a mild impact on your quality of life. And then we're comparing the dark histograms, that's the office treatment, versus kind of that lighter bluish gray bar, which would be the at-home phototherapy. And what we're seeing here across all different skin types, whether it's lighter skin or darker skin, is that the home phototherapy group did as good as the office group. Now, this was a non-inferiority study, so that's important to know because this wasn't designed to show superiority. But we can say numerically that the home group did as good, actually even better than the office group. Okay. And this is true whether it's the PGA or the DLQI. And what's probably the most astounding thing here is if you look at the skin type 5 or 6, that is really where you see the biggest delta, the difference between home use and office use. And I think a lot of that has to do with the adherence piece, right? Patients, if they want to get better, they have to be consistent and adherent. And that is particularly true for patients with darker skin tones. And so here, same study, but we're now showing you the number of patients that completed at least 24 treatments, which we think is kind of the minimum threshold where we're going to see a good response. And there are 3 times more patients in the home phototherapy group that achieved at least 24 treatments versus those in the office group. And that's not a surprise, right? If it's at home, you're much more likely to do it. And we know that doing it thrice weekly versus twice weekly will probably speed up the level of response by 1.5-fold as well. So being able to do this and being consistent with it will lead to the best results. One of the issues that we've come across with phototherapy, at least in the office, is that sometimes if we have a medical assistant that's not paying attention or they're new, right, or a nurse that's just kind of filling in, they may not be as attuned to or as experienced with how to calculate the dose. And so we have different phototherapy devices at our locations, and they are all a little bit different. Some are time guided, some are you got to actually put in a manual dose. But if you're missing a decimal point or you do an improper calculation, that is really where when you get into the issues of burning, right? Or giving someone too much of the medic or too much of the UV or too little. So the secret sauce for the Phothera units is what we call the guided mode controller, which simulates in-office decision making. And we'll show you how this really works, but it's dummy proof. I mean, it will ask the patient literally, how was your last treatment? Were you in pain or red after your last treatment? And they will just kind of click based on what their response was. And based on the answer, then it will calculate your next dose. And this dosing protocol is going to be based on the AAD protocol that we all use in our clinics. And so it really does take a lot of that guesswork out, but also minimizes the risk of improperly dosing your patients. These are some photos of what this actual guided mode looks like. So it's preloaded with the initial dose based on the skin type. So that's really all you need to do is decide what is the patient's starting dose based on the Fitzpatrick skin type. And then the patient will respond every time to the same question, asking them how they did at their last treatment. And then it will calculate based on this protocol from the AAD what that next dose is. And the device stores an electronic record for physicians. So if you want to review what is their actual dose, that gives you a sense of whether you need to make any type of adjustment. Okay, so we are now going to actually show you what this kind of operationally looks like. You'll see that you just press a key code to get in, and then a patient will be prompted with this question. Were you in pain or red after your last treatment? And they could pick one of 4 answers. Based on how they answer that, the machine will then calculate what their next dose is going to be based on the AAD protocol. On top, you can see the treatment dose. That is the final dose that they're going to get. Right below is the accumulative dose. And then lastly, you'll see the estimated time. So that's that safeguard and make sure that you're not getting too much or too little treatment. and you have the exit key there in red. So this is just really showing you how simple this is. I mean, really, anyone can learn how to do this much easier than having someone having to calculate the dose, which is what we used to do even for older phototherapy units. So I think this is certainly an advancement. So moving on here, and we're getting close to the end. Let's talk about some practical tips on how to get your patient started on home phototherapy. So there are four things that we're going to cover is how to select the proper patients, what protocol are we going to be using, which is very straightforward. It's just one protocol, and then just some practical tips of how to prescribe it and what are some pearls for those who may not have the best response. So first off, you select the right patient. Make sure they have a condition that can be treated by UVB therapy. So just make sure they don't have some type of photosensitizing condition. They're not on any photosensitizing medications. But psoriasis, AD, MF, vitiligo, these are all really good options. Of course, if a patient wants to come into the office and they want to socialize every time they come in, that's certainly a good option. But if they prefer to have it at home, which I think many of our patients will, then this is certainly a good option for those patients. You also want to make sure that the area that's involved is appropriate for phototherapy. So, patients who have widespread involvement, I think, are good candidates for phototherapy. But sometimes, if you have it like on your scalp, or if you have it in your genital skin, or your nails, or kind of palms or soles, it may be of benefit to also look at some of these other devices that are handheld and that you could locally administer to these areas. And I'll show you some photos of that. Of course, for joint involvement, this isn't going to do anything for. So if you have a patient with psoriatic arthritis, make sure that's being addressed with an appropriate treatment. And then you want to identify what are the barriers to the office. If they can't come in for whatever reason, right, or they have insurance concerns because they have a high copay or they're underinsured or uninsured, then there are ways that we can help with those patients. And then what are the barriers to home usage? Do they have the space to set up a unit? And that's going to really be the main rate limiting step. And keep in mind, even though there is a full size device, even if they don't have the space for that, you can use a smaller device, and we'll show you some photos. And we've had actually really good success, even in patients who live, let's say, in smaller apartments, of just using these smaller devices. We're showing you three of the devices that are available for your patients. If you start all the way to the right, that is kind of full body 600 3D 8 lamp. This actually folds, which is nice because it saves space in that regard. And this would be the most efficient way to administer UVB therapy to a larger body surface area. So that's the one that I use the most. You also, if you look in the middle, have the Phothera 200 units. This is a panel device that is going to be, I think, ideal for limited areas. So it's good for like the hand or foot, or if you have just localized plaques in certain areas, really good option. And you can see this is a smaller footprint, just 2 square feet. And then lastly, you have the 100 XL unit. This is a handheld device, really nice for spot treatment. So, the scalp might be hard to treat with a full body device, but for a handheld device, this could be really nice, especially for those tougher to reach areas. So you have all of these options available to you. Talk about contraindications. So the main absolute contraindications is if you have conditions like eczeroderma pigmentosum, basal cell nevus syndrome, or any type of photosensitive autoimmune disorders like lupus or dermatomyositis. On the bottom, these are more relative contraindications. So PMLE being a photosensitive condition, you want to be a little careful of. Although I will say sometimes we do use UVB therapy to kind of harden the skin for those who are more prone to polymorphous light eruption. So it could actually be a treatment as well. History of melanoma. For me, if you have a melanoma in situ, severely dysplastic nevi, or even a stage 1 melanoma, this isn't an absolute contraindication. For people with more advanced melanomas, I think that's going to be more shared decision making. History of non-melanoma skin cancer, again, not an absolute contraindication for me, but something that you want to talk about. Prior arsenic or ionizing radiation treatment, and those who are on heavy duty immunosuppression or organ transplant patients. Although I might disagree here, I will say we have plenty of patients that are transplant patients that we cannot put on a systemic agent because it may affect their other medications. So we freely treat those patients with UVB therapy as well. What are some of the common adverse events? Itching can sometimes happen early on, especially in atopic dermatitis, but that's why it's really important to apply emollients before and after. A photosensitivity, if you're on a photosensitizing medication, sometimes can happen. And then you can get tan and darker, and that is just expected with UVB therapy in general. Now, really the main decision you have to make as a prescriber is what's the starting dose, and we use the Fitzpatrick skin type to decide that. Historically, we've looked at skin color as a surrogate for skin type, but actually, what is more reliable is a patient's ability or inability to burn or tan. So you'll see that we now like to actually ask patients, hey, how, when you get sun, do you always burn? Do you usually burn? Do you sometimes burn, rarely burn, very rarely burn, or never burn? And I think that's a more consistent way of deciding what is the starting dose. And then you have um, different ways to administer or escalate the dosing of phototherapy. I really like the guided mode because, like as we said before, it's going to really adjust the dosing based on how you did the previous time. But there is this concept of photo adaptation, which means over time, your body, your skin gets used to the same dose. So you do need to go up. And then generally, what we're looking for is getting you to a dose where you're going to be slightly pink for less than 24 hours. One of the number one reasons why patients don't get better with phototherapy is because we are not giving them a therapeutic dose. It's sub-therapeutic. So we just need to keep pushing it, right? Of course, safely, but that is really where the guided modes can come into play. And especially for those who have Fitzpatrick skin type 5 or 6, we may have to push the dose even higher. Frequency. So generally, 3 times weekly is going to be more effective than twice weekly, or at least it gets you there faster. And if you're doing this at home, really doing it 3 times a week on non-consecutive days should not be an issue. And then it is recommended to use an emollient before you administer UV therapy. I like petrolatum or mineral oil, and that is really because it gets rid of some of that scaling or dry skin, which may reflect the UV therapy, helps it get concentrated and allows for deeper and more effective penetration. Now, if you're not improving, there's a couple things that you may want to think about. Number one is the dose adequate? That is the number one reason why someone doesn't respond. So you need to get the dose higher. Number two is, are you pre-treating them with an emollient to really help with that penetration? Three is the light therapy actually being delivered to the area that needs to be treated? So I've run into this situation when you have psoriasis, let's say below the knees, maybe the light box isn't getting to the distal legs as effectively. So that's when I have someone stand on a stool to get them higher up so that that penumbra of light could really get to where we need to treat. Or maybe they need combination therapy. Do you need to add on a topical or a systemic agent as well? As far as adverse events, burns, so most of the times I wouldn't call it a burn. They just might get pink and a little hot for maybe a little over 24 hours. And if that happens, then you have to wonder, did they recently start any medication that's photosensitizing? Did they get a lot of sun recently on vacation to a sunny place? That could also increase their propensity to burn. Are we doing it too frequently? And then as far as pruritus, sometimes that could be just a byproduct of having a disease like atopic dermatitis where you're just itchy in general. But sometimes you can get itchy after phototherapy. It's not that common. I have found that making sure patients are well moisturized though before and after treatment really helps with that. Now, for these next couple of slides, I'm actually going to invite one of our representatives for Phothera to kind of just walk you through the insurance coverage piece here.
Hi, Taylor Fields, and I am on the Phothera team. And with the merger of NatBio and Davlin, that has really opened up our access to hundreds of insurance policies. So really widening that coverage for patients to get in-office benefits, or excuse me, in-network benefits. So with that, we also are now working with multi-plan or Claritative, giving us even more secondary contracts to get those patients better coverage. We have also developed a financial assistance program for patients, really trying to take the burden off of them. We definitely do not want cost to be a barrier. The essential goal is to get these patients well and have access to the light therapy, no matter what insurance they have. We are also really trying to get minimal cost. So if a patient does end up going through insurance and has a bill, or if they do have any kind of financial burden or hardship, we just ask that they call us. We're really just trying to help everybody. We'll do what we can. The main goal again is to get patients well. The priority is to get them a home unit. The Shipment times we've really improved on. Devices are typically shipping within 5 to 7 days at no cost to patients. And as Dr. Song said, guided mode is kind of the go-to now. We're really trying to make that the standard of care, as it's essentially having a nurse right by their side, but at home. And then just always improving on our customer support with patients and providers. So really, we're just trying to do the best we can to help more patients get access to this equipment.
Hi, everyone. Robert, taking over from Taylor. And Dr. Song spoke earlier about the guided mode being easy and simple for patients, which is great. That's one of the things we hear is how easy guided mode is. But looking at that from a perspective of ensuring comfort and empowerment from the very beginning to the very point of treatment is also a very key detail that we as a company look at. How can we ensure that every patient from the moment they're prescribed a device has the information in hand to know that as soon as that device arrives, they can start treating and they know exactly what's doing that. So we accomplish this in a few various ways. Taylor touched on it a little bit. We have every device comes with a insert, and on this insert is quite a few helpful support resources, encouragement, a sense of patient community, along with some quick start tips. Did you remember your goggles? Make sure you do this, avoid this. All those kind of FAQs that we hear consistently across, we try to address those right up front so that the patient knows from the very beginning what to do. There's also a helpful QR code that you can see there on the one page that if a patient scans it, it will take them to our website where they can self-select their device that they have. And from that, we have curated landing pages that have helpful support videos, how-tos, how to set up your device, how to get started with the treatment, how to identify what controller you have, how to utilize the controller that you have, and so on and so on. So that is from the point of receiving the device, but what about from the moment of prescription to that point? So we took a step further and now we integrate texting and emails into that process as well. So all along the patient journey from the moment of speaking with their doctor to receive their device, patients will receive timely based emails and texting that give them updates about where their order is at in the process, whether it's in the shipping stage, the insurance benefit stage, your device is shipped. The emails provide helpful tutorial links to, again, that landing page. All of these emails are curated and tailored specifically for that patient. So if a patient gets a Phothera 600 3D, all of those emails and texts will be specific to that with links for that. Same with any other device. Again, our goal with all this is to ensure that the patient, from the very moment of prescription, they're informed, they're empowered, and they feel confident moving forward. As soon as that device arrives, they're excited, they can get treated. And as we've mentioned before, and Dr. James Song went over, as guided mode is there as that point that just helps them, brings everything full circle. So they're trained from the beginning and guided mode takes over, and then it's just a seamless integration from A to Z. So
hi, everyone. Brett DiCello here from Phothera as well. Final steps here. How do you prescribe? We've got kind of two options available for you here. And if I can share my screen for a second, I will walk you through how to do that. So go ahead. And all right, everybody, Dr. Song, can you see my screen? Just give me a thumbs up or no. Okay.
I, I think I may need to stop sharing, and
Okay.
then it might be easier. Could you send it to me?
Sure. Yeah. Oh, it's actually just through our website.
Okay. You want to just maybe, I'm gonna
I can
stop
walk
sharing
you.
here.
I can walk you through a demo live. How about, there we go. That'd be great.
Yeah. Yeah.
Actually, it would be better if I could log in to that
Okay.
portal. Let me see if I stop sharing.
Yeah.
Okay. Okay. All right. We good to demo? All right. Good deal.
Yeah, Brett, hey, Brett, can you do me a favor? Just can you pick up as if you were just starting to talk?
Sure. Yeah. All right. Hi, everyone. Brett DiCello from Phothera here, and I'm going to show you how you can prescribe some of our phototherapy products. So we have two options available to you. You could use either the eForm or the ClearLink provider portal. But first, what you want to do is you want to go to phothera.com. It'll take you to our home page, and then go up in the right-hand corner and just click Start Prescribing. And then it'll take you to our prescribing page, two ways to prescribe. First thing I'll show you here is our eForm. And this will kind of mimic some older fax forms, but this is all handled electronically. No paper, nothing like that, very green. So basically, the first thing you would do is you would enter your patient information here, type in the fields, date of birth, address, all that good stuff there. Move down to the diagnosis. Pick one, psoriasis, one of the diagnosis codes. We've the ICD-10 codes, select one of those, select the patient's skin type. We've highlighted the three products in the deck here for you. So you can go ahead and select one of those. Again, picking something based on the BSA that would sort of get all of the affected surface area. So we pick one of those. We have a lamp type. And just like this, we can go through, customize the order, selecting guided mode. Everything is we've designed this to be default to the main selections, to some of the recommended selections here, but you can sort of adjust this as needed. Then we have some insurance-based questions here. These are pretty typical of a lot of questions that like a typical office administrative staff or a biomedical technician would fill out. So don't feel like you as the clinician or prescriber needs to fill all of this out. This is typically pretty standard. So you or a member of your team could fill this out. And then once you get through, upload medical records, patient ID, insurance cards, things like that, just in a PDF format. You would sign here and click submit and enter the date. And so that's the eForm methodology for prescribing. Let me go back here. And now, so that's kind of a way to do single prescriptions. It's very convenient. Just go right to the website. Don't necessarily have to create an account. But if you want a way to create your own practice, manage your own set of patients that you see regularly, then we definitely recommend you use the ClearLink provider portal. So we would click on the portal. The sign up is in the right-hand corner here, or you could use your login as well. I will use my test account here to go ahead and log in. And now, to build the practice, you may want to have an admin or a member of your staff start this and then start inviting other users to join the practice. So for instance, if I go up to my, this is my account here, you can sort of add different individuals to go through and add like a clinician or other people to the account here. So I've already built out a couple patients here. So I'm going to go ahead and I'm going to create a new prescription for myself. And then I have a list of prescribers that I could call out as being the doctor on the prescription. Select the device type, UV home phototherapy. Click one of the devices. go through. We've pre-populated a lot of our sort of recommended configurations for the product. So you don't have to worry about filling any of this other stuff out. We've got our diagnosis code here that we would select based on the patient's skin, select the patient's skin type, body affected surface area, select severity. Again, this is stuff that your nurse or an office administrator could fill out and then send off to your account for final review and signature prior to submitting to Phothera. So, we go through, answer these questions, do phototherapy, yes, yes. Just kind of selecting the different reasons here, any sort of special instructions you want to provide. And now this is where we get into kind of the guided mode protocol section. What we've done is we've pre-populated this with the AAD recommended guidelines for how to handle these phototherapy protocols. So you don't actually have to adjust any of these parameters here if you don't want to, or if you're unsure. You come down here and click Submit Prescription. And now this prescription is ready to review. I have the clinician here who's listed, this prescription will go off to. Go through and review this. Either if I'm logged in right now as the clinician, but if I was logged in as the administrator, I could click send for signature, and it would go off to the clinician's account to review and sign, maybe something like at the end of the day. And so just like that, that is both of the prescribing methods of how you could prescribe our devices. With that, I'll kick it back over to Dr. Song.
All right, thank you, Brett. So we are coming to a close here, and we talked a lot about the clinical utility of using phototherapy and how we've addressed a lot of the limitations with home photo or with in-office phototherapy. But just to recap, narrowband UVB, it's an effective, safe, and cost-efficient FDA-approved treatment for many different skin conditions like psoriasis, AD, vitiligo, MF, and pruritus. This can be used as a legitimate first-line agent, either as monotherapy, or we could combine it with topicals or systemic medications as biologics. So you have a lot of versatility and flexibility there. And we've also showed you from a large randomized study of over 700 patients that were randomized to phototherapy, that in-office therapy versus home phototherapy, that home phototherapy is as good and actually numerically even more effective with much better adherence rates in patients who got it administered at home versus those who had it in the office. We talked about the guided mode, how this addresses some of the limitations that we may have had in the past with how to properly dose these patients. It simplifies that so patients can feel very comfortable doing it themselves. And it's preloaded with the AAD protocols to make sure that they're getting the right dose. And this is broadly covered at your institution. So as Brett and Taylor kind of walked us through, this should be something that is accessible for most of your patients. And Phothera is committed to reducing any cost barriers that your patients may have. They're continuing to work with insurance on coverage and denials and offer patient assistance programs to help alleviate any out-of-pocket costs. So with that, I truly do thank you for your kind attention and time and allowing us to speak to you about something that I think is going to be really a great addition to our armamentarium in treating patients with inflammatory skin disorders. Thank you so much.